Bismillahirrahmanirrahim. We were studying about mitral regurgitation in the last session. So continuing from there. So mitral stenosis caused by the rheumatic fever. It is basically in most situations under acute settings. The rheumatic fever causes mitral regurgitation. The one we have talked about just previously. Yes, that was aortic regurgitation that we were talking about. But okay, but in most situations, the acute rheumatic fever causes mitral regurgitation or aortic regurgitation, and under chronic situations, the rheumatic fever will cause mitral stenosis. So most commonly it is caused by rheumatic fever present with the exertional dyspnea, arrhythmia, and orthopnea. Severe mitral stenosis will lead to left atrium dilation. Now just think about this situation. Like suppose this is a normal heart and due to some reason it has stenosed mitral valve. Now the blood will that is coming from the pulmonary veins into the left atrium will start pooling here, and this left atrium will start dilating. From the anatomy, if you remember, the left atrium is the most posterior structure of the heart, right? Now, for this most posterior structure, it is lying over the esophagus, over the trachea, so it can cause over the recurrent laryngeal nerve in close proximity to that, so it can cause problems over there. So since it is dilating, firstly, it can alter the conduction and produce atrial fibrillation. Secondly, it compresses the esophagus, resulting in dysphagia for solids but not liquids. Compresses the left recurrent laryngeal nerve, resulting in the hoarseness that is called as the Ordner syndrome. Pulmonary congestion, infective endocarditis which is late and highly specific sequela. Auscultation findings, mid diastolic rumble, like this is opening snap, then we have a mid diastolic rumble, and then comes S1 sound. Mid to late diastolic murmur heard after the opening snap. The opening snap is click that corresponds to the abrupt halt in the valve leaflet motion in diastole after rapid opening due to the fusion of leaflet tip. It is best heard at the apex. Time between the A2 and the opening snap inversely correlates with the severity. If the time is less, inverse correlation means that this is A2, this is opening snap. If the time decreases, the severity increases, and if the time is more, the severity is less. So closer the opening snap is to the aortic stenosis, the worse is the prognosis, the worse is the situation. This is the mitral stenosis. It is also going to cause like it's a severe situation. Moving forward, we have hemodynamics in the mitral stenosis. Pressure is propagated proximally to the stenosis that increases the pulmonary capillary wedge pressure. Pressure not increased past the stenosis left ventricular end diastolic pressure is typically normal. So left ventricular end diastolic pressure will be normal, but the pulmonary capillary wedge pressure will be higher, and transmitral gradient will be elevated. Like this is mitral valve, above it left atrium, below that left ventricle. The gradient between these two is increased. Okay. Like suppose this is 25 millimeters of mercury diastolic pressure, and this becomes 40 millimeters of mercury because of excessive cooling of the blood and a very stubborn mitral valve, and so the blood cannot pass, so the pressure is raising over here. So the gradient elevates. Hemodynamic consequences of the mitral stenosis. Firstly, stenotic mitral valve will cause an increased pressure gradient between the left atrium and left ventricle. That can cause an So if there is an increased pressure gradient between the left atrium and left ventricle, severe stenosis can decrease the left ventricular filling and cardiac output. This increased pressure gradient can lead to increased left atrial pressure and volume, which promotes atrial fibrillation and mural thrombus formation. Increased pressure and volume of the left atrium causes increased pulmonary venous and capillary wedge pressure, which can cause pulmonary edema and alveolar hemorrhage. Now, this increased PCWP will lead to pulmonary hypertension, decreased pulmonary vascular compliance due to vessel constriction and obliteration, and pulmonary hypertension can lead to increased right ventricular pressure and volume with eventual right-sided heart failure. Again, you can see that left-sided problems are the most common etiology for the right-sided heart failures. And this can cause tricuspid regurgitation, venous pressure, increased jugular venous pressure, and peripheral edema. Then comes the mitral valve prolapse. Systolic murmur, redundant valve tissue results in bulging of one or both the leaflets into left atrium during the systole. Possible regurgitation also causes. Abnormal valvular growth, excess production of valve substance that is dermatan sulfate, chronic rheumatic fever, myxomatous degeneration, coda tendini rupture, usually isolated abnormality but may be associated with the Marfan's syndrome and Ehlers-Danlos syndrome and atrial septal defect. Presentation: most patients are asymptomatic. If symptoms are present, then the patient will present with palpitation, chest pain not associated with the coronary artery disease or MI, exertional dyspnea, fatigue, cough, and orthopnea. It rarely presents with a panic disorder and may palpate thrill over the chest wall. Auscultatory findings are mid-systolic click due to sudden tension of coda tendini. Decreased preload moves the click closer to S1, best heard over the apex, loudest before S2, and usually it is benign. Late systolic crescendo murmur if regurgitation is present. So if regurgitation is also present in the setting of mitral valve prolapse, then we can find a late diastolic murmur. Late systolic crescendo murmur. Okay, this one. This is the mid-systolic click of the mitral valve collapse, and if regurgitation is also there, so we can find a crescendo murmur that is late systolic. So this is left atrium, left ventricle, and what is this? This is PML. What does that mean? PML. I don't know. Protruding mitral valve, something. I don't know. What is the meaning of PML? Okay, so here you can see that when the ventricle undergoes systole, the blood is moving into the aorta, but for the weak mitral valve, it prolapses upwards, and then blood can also regurgitate into the left atrium. And then we have delayed mitral valve collapse, tightening of the coda, and increased venous return secondary to squatting. Okay. Complications include the risk of coda tendinae rupture, mitral regurgitation, systolic murmur, retrograde blood flow into the left atrium that occurs throughout the systole, leading to increased left ventricular and diastolic volume and increased left atrial volume. Late manifestation in chronic kidney disease include left atrial dilation and left ventricular dilation and hypertrophy. Causes: chronic rheumatic fever and infective endocarditis, coda tendinae rupture, mitral valve collapse, and ischemic heart disease post myocardial infarction. It presents with dyspnea, orthopnea, and fatigue. Symptoms occur if regurgitation develops acutely or if atria can no longer compensate in the chronic disease. Auscultation findings: hollow systolic pan-systolic murmur. It is loudest at apex and radiates to axilla. Best heard with the patient in the left lateral decubitus position. Does not change with inspiration. Contrast the tricuspid insufficiency or regurgitation, which increases during inspiration. So this is mitral regurgitation, like there is a hollow systolic murmur, and it does not change during inspiration, but it is best heard with the patient in the lateral decubitus position, left lateral decubitus position. Then mitral regurgitation hemodynamics. In acute mitral regurgitation, the preload increases. Because blood is actually not leaving the heart, it is pulling inside the blood, so that increases the preload. Afterload will be decreased. Yes, why will afterload decrease? Because for the ventricle, now instead of one pathway, that is aorta, we have two pathways, that is left atrium and aorta. So it is also moving into the aorta and also into the left atrium. Contractile function will not be affected. Ejection fraction will increase because ejection fraction is the total fraction of blood that is leaving the left ventricle. So now because of two pathways, more blood is leaving the left ventricle per systole. Forward stroke volume will decrease. Like this is the forward stroke volume, and that will decrease because some of it is going into the left atrium. For compensated mitral regurgitation, the preload is minimally increased, afterload is not decreased, contractile function is not affected like before, ejection fraction is increased but to a lesser extent, and forward stroke volume is normal. For the decompensated mitral regurgitation, the preload increases, afterload increases, the contractile function decreases, ejection fraction decreases, and stroke volume also decreases. Okay, so variables as compared to the normal heart function. Now we have mitral regurgitation, so you can see that in the mitral regurgitation with afterload reduction, okay, so this was mitral regurgitation. If we give vasodilators and if we reduce the afterload, so more blood will start moving into this direction instead of going back to the left atrium. So that is how it works. Tricuspid regurgitation. It is a systolic murmur, retrograde blood flow into the right atrium that occurs throughout the systole, similar to mitral regurgitation. Mitral regurgitation or insufficiency, but softer due to the low pressure in the pulmonic circuits. Then the causes: carcinoid heart disease. In carcinoid heart disease, begin with when GI tumor metastasizes to the liver. Okay, so basically when it is confined to the small intestine, due to the first pass metabolism, liver detoxifies whatever the tumor is producing. But once it metastasizes to the liver itself, now the detoxification function of the liver is impaired. And any hormone produced distal to the liver in the venous system metabolized by the monoaminoxidase in the lung. Okay, so produces 5 hydroxytryptamine, which fibroses tricuspid and pulmonary valves. IV drugs result in the right heart endocarditis, staph aureus. It presents with a pulsatile liver due to the increased venous pressures behind the right heart. Auscultation findings. There will be hollow systolic pan-systolic murmur. Increased intensity during expiration due to the increased venous return to the right heart. Now comes the vasculitis. The basic principle, it is a blood vessel inflammation as the name indicates. So the basic principles are, etiology is usually unknown. Most cases are not infectious. The clinical features include non-specific symptoms of inflammation like fever, fatigue, weight loss, and myalgias. Symptoms of organ ischemia due to the luminal narrowing or thrombosis of the inflamed vessels. Divided into large, medium, and small vessel vasculitides. Large vessel vasculitides involve the aorta and its major branches. Medium vessel vasculitis involves muscular arteries that supply organs, and small vessel vasculitis involves arterioles, capillaries, and venules. For the large vessel vasculitis, the first one is temporal or giant cell arteritis. It is basically, all the vasculitis are confusing disorders and overlapping symptomatology is present. Some things are very specific to a particular disease. You must remember, like for the temporal arteritis, it is the person who will come to you will be an old age woman, in most scenarios. Secondly, there will be a palpable temporal artery in the temple, in the temporal region, right? Then you have to perform the ESR, and before the ESR result comes to your table, you have to start giving the corticosteroids, because in this disorder, even if you are suspecting this, there is a high chance of ophthalmic artery occlusion, and if that happens, there is a risk of blindness. To avoid that, we have to give the woman corticosteroids. So granulomatous vasculitis, it classically involves a branch of carotid artery. Most common form of vasculitis in older adults, more than 50, and usually affects the females. Giant cell arteritis is the clinical manifestation. Systemic symptoms are fever, fatigue, malaise, and weight loss. Localized symptoms are headache, localized in the temporal area. Jaw claudications, most specific symptom of giant cell arteritis. PMR, what is that? PMR is polymyalgia rheumatica. Then we have arm claudication associated bruise in subclavian or axillary areas. Aortic wall thickening or aneurysms. Now, these bruises in the subclavian or axillary areas are diminished pulses and or bruise over axillary, brachial or femoral arteries and over supraclavicular and or carotid areas. Aortic wall thickening or aneurysm followed by serial chest X-ray. In the CNS, transient ischemic attack, stroke, vertigo, and hearing loss will be there. The visual symptoms are amaurosis fugax, transient vision field defect progressing to monoocular blindness, AION, which is anterior ischemic optic neuropathy, most common ocular manifestation. Fundoscopy will show swollen and pale disc with blurred margins. Lab results will show normochromic anemia, elevated ESR and C-reactive protein, and temporal artery biopsy. Treatment: polymyalgia rheumatica only, low dose oral glucocorticoids, for example, prednisone 10 to 20 mg daily. Giant cell arteritis, intermediate or high dose oral glucocorticoids, for example, prednisolone 40 to 60 mg daily. And giant cell arteritis with vision loss, pulse, high dose IV glucocorticoids like methylprednisolone 1000 mg daily for 3 days, followed by intermediate to high dose oral glucocorticoids with slow taper over several months. Okay, so if it is polymyalgia rheumatica only, so then low dose oral glucocorticoids like prednisone 10 to 20 mg. If it is giant cell arteritis, intermediate or high dose oral glucocorticoids, prednisone 40 to 60 mg. And if it is giant cell arteritis with vision loss, then pulse high dose IV glucocorticoids like methylprednisolone 1000 mg daily for 3 days, followed by intermediate to high dose oral glucocorticoids. Aortic aneurysm can happen in people with giant cell arteritis. Okay. Then biopsy, inflamed vessels with giant cells and intimal fibrosis. Lesions are segmental. Diagnosis requires biopsy for long segment of vessels, and a negative biopsy does not exclude the disease. Tocilizumab can be used with corticosteroids. Production of interleukin 6 is highly associated with severity of the disease. Polymyalgia rheumatica, pain and stiffness in the shoulders and hips, does not cause muscular weakness. Fever, malaise, and weight loss. Associated with giant cell temporal arteritis. Increased ESR, increased C-reactive protein, and normal keratin kinase. rapid response to low dose glucocorticoids. Then the second type of giant cell arteritis, or not the giant cell arteritis, the second type of large vessel arteritis is Takayasu arteritis. Now, for the Takayasu, as the name indicated, there will be some Asian woman with diminished pulses in one arm. So basically, one arm will be pulseless, other will be having normal pulses, and she will be hypertensive. Yeah, it is also called as pulseless disease. So granulomatous vasculitis that classically involves the aortic arch and branch points. Patients in adults less than 50 years old, classically young Asian female, pulseless disease. Takayasu arteritis respect to the female, Asian and age less than 40. The clinical laboratory findings: constitutional symptoms like fever, weight loss, and fatigue. Arterio-occlusive claudications, blood pressure discrepancies, bruise, and pulse deficits will be there. Visual and neurological deficits, arthralgias and myalgias, and elevated inflammatory markers, for example, C-reactive protein and ESR. Histopathology, granulomatous inflammation of arterial media, transmural fibrosis, fibrous thickening and narrowing of the lumen, and predominantly affects the aorta and its branches. The treatment is with corticosteroids. Then come the medium vessel vasculitis. The first one is polyarteritis nodosa. It is important because it has an association with the hepatitis B. So necrotizing vasculitis involving multiple organs and lungs are spared. So it is very important for one reason or the other. Somehow it spares the lung. It does not involve the pulmonary vasculature. So that is a good thing about it. But rest is all bad. Usually it affects the middle-aged men, and it is associated with serum SP surface antigen. The clinical features of polyarteritis nodosa are systemic findings include fever and weight loss. The skin findings include nodules, livedo reticularis, ulcers, and purpura. The renal manifestations are hypertension, renal insufficiency, and arterial aneurysms. The nervous manifestations are headaches, seizures, mononeuritis multiplex. Gastrointestinal include mesenteric ischemia and infarction. The musculoskeletal problems are myalgias and arthritis. And others include myocardial ischemia, renal ischemia, and orchitis. Diagnosis: negative ANCA and anti-neutrophilic antibodies. Association with hepatitis B and hepatitis C. Microaneurysm or arteriography, and tissue biopsy confirm the vasculitis that is non-granulomatous. Treatment is prednisone and cyclophosphamide, and ACE inhibitors or for the hypertension can also be administered. Biopsy: lesions of varying stages are present. Early lesion consists of transmural inflammation with fibrinoid necrosis. Eventually heals with fibrosis, producing a string of pearl appearance on imaging. So this is, I guess, renal arteriogram. And what is that showing? That was showing something. What was that showing? The renal arteriogram. Maybe arterial aneurysms are present, like the big dots are like this is an arterial aneurysm, this one, maybe this one. Okay, then we have Kawasaki disease. Kawasaki disease is important because it is the only condition in which aspirin is advisable to the children. Otherwise, aspirin is strictly contraindicated to the children. And secondly, there is a mnemonic for that, I think, crash and burn. Now I don't know the full form of it, but okay. So the very first thing is classically affects the Asian children who are less than 4 years of age. Presentation is fever for more than 5 days plus 4 of the following findings. Firstly, there will be fever with 4 of the following findings. Bilateral non-exudative conjunctival injection, cervical lymphadenopathy, mucositis, that is erythema of palatine mucosa, fissured erythematous lips, and strawberry tongue. Then we have extremity changes, which include edema of the hands and feet, erythema of palm and soles, desquamation of the fingertip, that is periungual. There will be rash. Okay. Polymorphous, usually urticarial, erythematous rash on the extremities that spreads centripetally to the trunk. And a serious complication of Kawasaki disease is coronary artery inflammation leading to the development of coronary artery aneurysm. Treatment is aspirin and IV immunoglobulin. Disease is self-limited. So this is Kawasaki disease, bilateral non-exudative conjunctivitis, then mucositis, coronary artery aneurysms, swelling and or erythema of the palms and soles. There will be rash, cervical lymph node more than 1.5 centimeter, and fever for 5 days. Okay, so this is strawberry tongue, and here you can see coronary artery aneurysms in the left anterior descending artery. The next thing is Burgess disease. So thromboangiitis obliterans or Burgess disease. Etiology: segmental small and medium-sized vessel vasculitis, likely triggered by the tobacco smoke. The clinical features: age less than 45, predominantly men, digital ischemic ulceration and limb claudications, Raynaud phenomena, and superficial thrombophlebitis. Now, For the Behçet's disease, think of a smoker male, middle-aged, who is presenting to you with Raynaud phenomena. And yeah, so histopathology will show inflammatory interluminal thrombi with vessel wall sparing and extension into the contiguous veins and nerves. Segmental vasculitis that extends into the contiguous veins and nerves. Necrotizing vasculitis involving the digits. It is highly associated with heavy smoking, hypersensitivity to the intradermal tobacco injection, and treatment is smoking sedation. So here you can see it. Then comes the small vessel vasculitis. So first one is the Wegener's granulomatosis. If you have heard pathoma, so it is also called as Wegener granulomatosis for two reasons. Firstly, that uh, it involves sinuses, the lungs, and the kidneys. So like a C is formed. And it includes C and K. Yeah. So that is why it is also called as. So now let's read it. Presentation: upper respiratory tract will show perforation of the nasal septum, chronic sinusitis, otitis media, and mastocytitis. Lower respiratory tract will show hemoptysis, cough, and dyspnea. The renal manifestations will include hematuria and red cell casts. Biopsy triad will show focal necrotizing vasculitis, necrotizing granulomas in the lung and upper airway, and necrotizing glomerulonephritis. PR3 NK antiproteinase 3 level correlates with the disease activity. Treatment is cyclophosphamide and steroids. Relapses are common. Then we have microscopic polyangiitis, necrotizing vasculitis involving multiple organs, especially the lungs and kidneys. Presentation is similar to Wegener's granulomatosis, but nasopharyngeal involvement and granulomas are absent. Palpable purpura can be present. Serum MPO-NK or PNK anti-myeloperoxidase level correlate with the disease activity. Treatment is corticosteroids and cyclophosphamides, and the relapses are common. So what are these? These are, I guess, immunofluorescent pictures. I think so. Then we have Behçet syndrome. This word is Turkish, so high incidence in the Turkish and Eastern Mediterranean descent. Recurrent aphthous ulcer, genital ulceration, uveitis, and erythema nodosum. It can be precipitated by HSV or parvovirus. Flares last 1 to 4 weeks. Immune complex vasculitis, and it is associated with HLA-B51. Eosinophilic granulomatosis with polyangiitis or Churg-Strauss syndrome. Necrotizing granulomatous inflammation with eosinophils involving multiple organs, especially the lungs and the heart. Asthma and peripheral eosinophilia are often present. Other symptoms are sinusitis, skin nodules or palpable purpura, peripheral neuropathy, for example, wrist or foot drop, can involve the heart, GI, kidneys, post-immune glomerulonephritis. Serum P and K levels correlate with the disease activity, and there will be increased amount of IgE as well. Then comes the Hinox-Shaolin purpura, IgA vasculitis. So the classic picture of Hinox-Shaolin purpura is that there will be a child who will present to you after upper respiratory tract infection or GI infection, and now he's having rash on the buttocks, on all of the body, and polyarthralgias and stuff like that. So it is because, and that is happening because of IgA immune complex deposition in multiple areas of the body. So vasculitis is due to the IgA immune complex deposition, most common vasculitis in children. Disease is self-limited but may recur treated with steroids if it is severe. Hinox-Shaolin purpura, the pathogenesis is IgA immune complex mediated vasculitis, generally follows the upper respiratory or other minor infections. The clinical manifestation is palpable purpura, arthralgias, abdominal pain, intussusceptions, renal disease similar to IgA nephropathy and hematuria. The diagnosis is usually made clinically confirmed by skin biopsy showing the IgA deposition in the blood vessels. Then the Uworld point is that intranasal ulcers with oliguria. So the diagnosis is vagus. Because the upper respiratory tract is involved in the vagus granulomatosis. Then late onset asthma with inability to dorsiflex the disc with eosinophilia, so that is Churg-Strauss, characterized by the late onset asthma, rhinosinusitis, and eosinophilia. Peripheral nerve involvement like mononeuritis multiplex frequently occurs as a result the associated vasculitis affecting the epidural vessels. Then we have varicose veins. Varicose veins are dilated tortuous veins resulting from impairment of the venous valves and reflux of the venous blood. This leads to venous stasis and congestion, edema, and an increased incidence of superficial venous thrombosis. Thromboembolism is very infrequent complication of varicose veins, while venous stasis ulcers are very common and often occur over the medial malleolus. Okay, so this is venous stasis dermatitis, this thing, and also over here. Then we have Uworld point, that is Plagmasia alba dolens. Painful white leg, milk leg is a consequence of iliofemoral venous thrombosis occurring in the peripartum women. Pregnancy period exposes to the deep venous thrombosis due to the pressure of the gravid uterus on the deep pelvic veins, producing venous stasis, as well as increased hypercoagulability. Lightning related complications. Lightning like the lightning that falls on you from the sky, right? So the cardiac complications can be cardiac arrest and arrhythmias. Neurologic complications can be peripheral nerve damage, seizures, confusion, respiratory arrest, and autonomic dysfunction. Dermatologic manifestations include Lichtenberg figures, pathognomonic of lightning strikes and burns, musculoskeletal rhabdomyolysis, bone fractures and compartment syndrome, and others include cataracts, late sequelae, ruptured tympanic membranes, and curling ulcers. The uveal point is alveolar cells containing golden cytoplasmic granules that turn dark blue with Prussian blue staining. The diagnosis is hemosiderin-laden macrophages. NBME point is the Prussian blue detects the iron, that is hemosiderin. Then NBME point is golden yellow cytoplasmic granules of brown pigment is one of the two options. Hemosiderin detected by the Prussian blue pigment and lipofuscin is not detected by the Prussian blue. A Uworld point is persistent lymphedema with chronic dilation of the lymphatic channels predisposes to the development of lymphangiosarcoma, a rare malignant neoplasm of the endothelial lining of lymphatic channels. This cancer may arise approximately 10 years after the radical mastectomy and axillary lymph node dissection for the breast cancer. Okay. Then we have a Uworld point. A 23 years old Caucasian male who notes recurrent severe nosebleeds is found to have pink spider-like lesion on his oral and nasal mucosa, face and arms. The patient most likely suffers from Osler-Weber-Rendu syndrome. It is a very important question. They ask you about this Osler-Weber-Rendu syndrome, in which they will tell you about pink spider-like lesions on the oral, like telangiectasias on the oral and nasal mucosa with the face and arms. So, Osler-Weber-Rendu syndrome, which is hereditary hemorrhagic telangiectasia, is an autosomal dominant condition marked by the presence of telangiectasias in the skin, as well as the mucous membrane of the lips, oronasopharynx, respiratory tract, gastrointestinal tract, and urinary tract. Rupture of these telangiectasias may cause epistaxis, gastrointestinal bleeding, or hematuria. Then we have mediastinal pathology. So, for the mediastinal pathology, normal mediastinum contains heart, thymus, lymph nodes, esophagus, and aorta divided into compartments. The mediastinal masses, the blue one is the mediastinum. In this pictures, you can see the blue one is the mediastinum and the red is the middle and posterior. So, I'm sorry, the blue is the anterior mediastinum. This is the middle mediastinum. This is anterior. This one is middle, and this is the posterior mediastinum. Okay. Till the Xiphus sternum, not Xiphus sternum, till the sternal notch or the sternal angle, we have superior mediastinum. Below that, we have inferior mediastinum. So some pathologies like lymphoma, lung cancer, abscess can occur in any compartment, but there are some associations, common associations, like in the anterior mediastinum, we have 4 T's, that is thyroid, thymic neoplasm, teratoma, and terrible lymphoma. In the middle portion, we have esophageal carcinoma, metastasis, hiatal hernia, and bronchogenic cysts. And in the posterior part, we have neurogenic tumor like neurofibroma and multiple myeloma. Mediastinitis, inflammation of the tissue in the mediastinum, commonly due to the post-operative complications of the cardiothoracic procedures. Pathology less important is esophageal perforation or contiguous spread of the odontogenic retropharyngeal infection. Chronic mediastinitis, also known as fibrosing mediastinitis, due to increased formation of connective tissue in the mediastinum. Histoplasma capsulatum is common cause. The clinical feature are fever, tachycardia, leukocytosis, chest pain, and especially with the cardiac procedure, sternal wound drainage. Pneumomediastinum, presence of gas yielding air in the mediastinum. Black arrows show air around the aorta and red air show air dissecting into the neck. Can either be spontaneous due to rupture of pulmonary bleb or secondary like trauma, iatrogenic Borheim syndrome. Ruptured alveoli allow the tracking of air into the mediastinum via the peribronchial and perivascular shafts. The clinical features like chest pain, dyspnea, voice change, subcutaneous emphysema, positive Hamann sign, crepitus on cardiac auscultation. So it is the crepitus that is heard on the cardiac auscultation. That is a Hamann sign that is present in the pneumomediastinum, which can be because of Borheim syndrome or trauma like because of air in the mediastinum. Okay, and it can be associated with pneumothoraces. Then we have CVS pharmacology. So let's first talk about the hypertension treatment. Firstly, for the primary or essential hypertension, thiazide diuretics, ACE inhibitors, angiotensin II receptor blockers, dihydropyridine calcium channel blockers. For the hypertension with heart failure, in these situations, we prefer diuretics, ACE inhibitors, and angiotensin receptor blockers because they inhibit the cardiac remodeling. Beta blockers for compensated heart failure. In acute heart failure, we are not supposed to give beta blockers because beta blockers will slow down the heart rate. If it is happening in acute settings, so it will worsen the situation. So beta blockers are recommended in compensated heart failure and also aldosterone antagonists. Beta blockers must be used cautiously in decompensated heart failure and are contraindicated in the cardiogenic shock. Hypertension with diabetes mellitus, ACE inhibitors and angiotensin receptor blockers, calcium channel blockers. Yeah, because ACE inhibitors or angiotensin receptor blockers, they prevent the diabetes mediated mesangial proliferation, and thiazide diuretics and beta blockers. ACE inhibitors, angiotensin receptor blockers are protective against diabetic nephropathy. Hypertension in pregnancy, hydrazine, labetalol, methyl-dopa, and nifedipine. The Uworld point is the most effective long-term treatment option of heart failure and hypertension is ACE inhibitors. They inhibit the myocardial remodeling and the associated deterioration of the ventricular contraction function. Also beta blockers. Uworld point is the treatment of isolated systolic hypertension in old patient. If diabetic, give ACE inhibitors, and if non-diabetic, calcium channel blockers, amlodipine, or thiazide diuretics. Okay. What are loop diuretics? Loop diuretics include furosemide, bumetanide, and torsemide. The mechanism of action is that they inhibit the sodium potassium 2 chloride channels in the ascending limb of loop of Henle. So sulfonamide loop diuretics inhibit the co-transport system sodium potassium 2 chloride of thick ascending limb of loop of Henle, abolish hypertonicity of the medulla, preventing the concentration of urine. Stimulates the prostaglandin E release, vasodilatory effect on the afferent arteriole inhibited by the NSAIDs, increased calcium excretion and loop lose calcium. The clinical use, admixture states heart failure, cirrhosis, nephrotic syndrome, and pulmonary edema, hypertension and hypercalcemia. Toxicity include, ototoxicity, hypokalemia, because anything that is acting proximal to all the diuretics which are acting proximal to the collecting duct are potassium wasters. So all of them can cause hypokalemia. Then dehydration, allergy by the sulfa drugs, nephritis, interstitial nephritis and gout. These are the complications. These are the side effects which can occur, or toxicity. Then ethacrenic acid, mechanism is phenoxyacetic acid derivative, not a sulfonamide, and essentially same action as furosemide. The clinical use is diuresis in the patients allergic to sulfa drugs. Toxicity is similar to furosemide and can cause hyperuricemia. Never use this to treat gout because it can cause hyperuricemia. Yeah. Then we have thiazide diuretics. So thiazide diuretics include chlorthalidone and hydrochlorothiazide. The mechanism is that it inhibits the sodium calcium reabsorption in early distal convoluted tubule. Yes, decreasing the diluting capacity of nephron and decreases the calcium excretion. If a person is having hypocalcemia, give thiazide diuretics. If the person is having hypercalcemia, then give loop diuretics because loop diuretics are calcium wasters. Loops lose calcium, while thiazide diuretics conserve calcium. We'll talk about the mechanism of conservation or losing of calcium when we do the renal section, inshallah, but for that, just remember this. The clinical use is hypertension, heart failure, idiopathic hypercalciuria, nephrogenic diabetes insipidus, and osteoporosis. Toxicity can cause hypokalemic metabolic alkalosis, hyponatremia, hyperglycemia, hyperglycemia, hyperlipidemia, hyperuricemia, hypercalcemia, and sulfa allergy. Then we have potassium sparing diuretics. So potassium sparing diuretics are spironolactone and eplerenone, triamterene, and amiloride. The potassium stays. The mechanism is spironolactone and eplerenone are competitive aldosterone receptor antagonists in the cortical collecting tubule. Triamterone and amiloride act at the same part of the tubule by blocking the sodium channels in the cortical collecting tubule. Yes, the spironolactone antagonizes the aldosterone, while the triamterene. So basically, spironolactone, the aldosterone causes the insertion of sodium channels on the luminal side and then causes the absorption of sodium. Spironolactone does not allow aldosterone to do that. While triamterene and amiloride, they bind to the sodium channels which are inserted by the aldosterone. So basically, they're performing a similar downstream action, but the mechanism of action is somewhat different. The clinical use is hyperaldosteronism, potassium depletion, and heart failure. Hyperkalemia can lead to arrhythmias. Endocrine effects with the spironolactone, for example, gynecomastia and anti-androgen effects. Then comes the diuretic electrolyte changes. So the first one is diuretic electrolyte changes. Urine NaCl increase with all diuretics except acetazolamide. Serum NaCl decreases as a result. So acetazolamide does not cause an increase in the urine NaCl. So what does it do? It increases sodium bicarbonate. Yeah. So serum NaCl may decrease as a result of this. Then urine potassium increase with the loop diuretics and thiazide diuretics. Serum potassium may decrease as a result. The blood pH decreases, that is acidemia, occurs with carbonic anhydrase inhibitors like acetazolamide because they decrease the bicarbonate absorption. Potassium sparing aldosterone blockade prevents the potassium secretion and H positive secretion. So that can also cause acidemia. Additionally, hyperkalemia leads to potassium entering all cells via hydrogen potassium exchange, and that can also cause hydrogen exiting the cells. So acidemia. Acidemia can be caused by carbonic anhydrase inhibitors like acetazolamide. Also, the potassium sparing like aldosterone and triamterene, aldosterone antagonists, basically, like specifically spironolactone, they cause decreased hydrogen excretion, right? So that can cause acidemia. And thirdly, hyperkalemia leads to potassium entering all the cells by hydrogen potassium exchanger in exchange for hydrogen exiting the cells. Increased alkalemia. Loop diuretics and thiazide cause alkalemia through several mechanisms. Volume contraction, increased angiotensin 2, that will lead to increased sodium hydrogen exchange in the proximal convoluted tubule, increased bicarbonate reabsorption, and contraction alkalosis. Potassium loss leads to potassium exiting all the cells by hydrogen potassium exchanger in exchange for hydrogen entering the cells. In low potassium states, hydrogen rather than potassium is exchanged for sodium in cortical collecting tubules that will lead to alkalosis and paradoxical aciduria. Yeah. So in low potassium states, hydrogen rather than potassium is exchanged for sodium, and in cortical collecting tubule, alkalosis and there will be alkalosis and paradoxical aciduria. Yeah, we'll talk about that in detail, but they're trying to say that suppose there's a collecting duct, and here we have like in low potassium states, normally when sodium is deabsorbed, potassium is dumped into the urine, right? But if we don't have enough potassium, so instead of potassium, the hydrogen is being dumped, and in blood we have alkalosis, while in the urine we have aciduria. So that is a paradoxical aciduria. Urine calcium increased with low diuretics, decreased paracellular calcium reabsorption that will lead to hypocalcemia. Decreased with thiazides, enhanced calcium reabsorption in the distal convoluted tubules. Renin, angiotensin, aldosterone system, and antihypertensives. So let's talk about the system first, and then we'll see which antihypertensive acts where. So angiotensinogen is converted to angiotensin 1 by renin, which is produced by the juxtaglomerular apparatus. Angiotensin 1 goes to the lungs, and where the angiotensin converting enzyme converts that into angiotensin 2. Angiotensin 2 causes the release of aldosterone that will lead to increased renal and sodium reabsorption. Also, angiotensin 2 causes systemic vasoconstriction and efferent arteriolar vasoconstriction. Increased renal sodium reabsorption and systemic vasoconstriction will lead to increased blood pressure, and efferent arteriolar vasoconstriction will maintain the GFR. Now, let's see the decreased renal blood flow and sympathetic stimulation causes the increased renal production. Beta blockers inhibit this pathway. Direct renin inhibitor like aliskiren can also inhibit the renin. ACE inhibitors like captopril and enalapril, they can inhibit the angiotensin converting enzyme. Angiotensin receptor blocker like losartan, valsartan, candesartan, they can inhibit the angiotensin 2 from binding its receptor. And also we have aldosterone antagonists like spironolactone, they can also inhibit the downstream action of the aldosterone, which is released by the renin. ACE inhibitors. ACE inhibitors are captopril, enalapril, lisinopril, and ramipril. The mechanism is they inhibit the angiotensin converting enzyme, decrease the angiotensin 2, and decrease the GFR by preventing the constriction of efferent arterioles. Levels of renin increase as a result of loss of feedback inhibition. Inhibition of angiotensin converting enzyme also prevents the inactivation of bradykinin, which is a potent vasodilator. The clinical use. hypertension, heart failure, proteinuria, diabetic nephropathy, prevents unfavorable heart remodeling as a result of chronic hypertension. In diabetic nephropathy, decreased intraglomerular pressure, slowing glomerular basement membrane thickening. Toxicity include captopril catch, that is cough, angioedema. It is contraindicated in C1 esterase inhibitor deficiency because in C1 esterase inhibitor deficiency we already have accumulation of bradykinin. On top of that, if we give angiotensin converting enzyme inhibitors, so whatever bradykinin was being broken down by the angiotensin converting enzyme itself, that will also not happen and that can precipitate angioedema. Then teratogens, fetal renal malformations, increased creatinine, decreased GFR, hyperkalemia and hypotension. Avoid in bilateral renal artery stenosis because angiotensin converting enzyme inhibitors will further decrease the GFR and there will be renal failure. Causes of angioedema, mast cell activation, type 1 hypersensitivity reaction like IgE mediated and direct mast cell activation, for example opioids. These are associated with pruritus and urticaria. Excess bradykinin can be caused by ACE inhibitors or C1 inhibitor deficiency, hereditary or acquired. No pruritus or urticaria will be there. Then we have a Uworld point. First dose hypotension can be potential limiting factor when initiating the ACE inhibitors. Significant hypotension is most likely to occur in patients with high plasma renin activity, such as those with volume depletion like diuretic use or heart failure. So the people who are having heart failure or maybe who have volume depleted, the renin is maintaining their blood pressure. So if there is if we administer ACE inhibitor, so the renin level will fall down and the person will undergo hypotension. Initiation of ACE inhibitor therapy causes abrupt removal of the vasoconstrictive effects of the angiotensin 2, resulting in decreased peripheral vascular tone and a precipitous drop in the blood pressure in susceptible patients. To prevent the development of first dose hypotension, therapy should be started at low doses and slowly titrated upward as needed. Then the next thing is angiotensin receptor blockers. Angiotensin 2 receptor blockers are losartan, candesartan, and valsartan. Mechanism is that they selectively block angiotensin 2 to angiotensin 1 receptor. Effects similar to ACE inhibitors, but angiotensin receptor blockers do not increase bradykinin. The clinical uses are hypertension, heart failure, proteinuria, or diabetic nephropathy with intolerance to ACE inhibitors like cough and angioedema. Toxicities with hyperkalemia, decreased renal function, hypotension, and teratogen. Aliskiren mechanism is direct renin inhibitor. It blocks the conversion of angiotensinogen to angiotensin 1. The clinical use is with hypertension. Toxicity of aliskiren can cause hyperkalemia, decreased renal function, hypotension, contraindicated in diabetics who are taking ACE inhibitors and angiotensin receptor blockers. Now, this is a flow sheet diagram in which they are showing the calcium channel blockers, nifedipine. What is that basically? This is the mechanism of smooth muscle contraction and relaxation and the drug affecting them. So let's start here. GS coupled receptor, beta 2 receptor. Okay, they will stimulate the adenyl 8 cycles, which will convert the ATP to cyclic AMP. Phosphodiesterase inhibitor. Okay, let's not talk about the drugs for now. Let's see the mechanisms first. Cyclic AMP will stimulate the protein kinase A, which will cause the myosin light chain kinase, which will phosphorylate that, and that will become activated, right? This myosin light chain kinase will stimulate the myosin light chain, which will be phosphorylated and activated. Okay. Yeah, so you can see myosin light chain kinase become active, and by the myosin light chain, this will also stimulate that, and myosin light chain plus actin. So yeah, now here you can see that the phosphodiesterase inhibitors, they inhibit the degradation of cyclic AMP into AMP and thus help in muscle contraction, right? Yeah, theophylline and enamidone. Okay, I'm sorry, this is muscle relaxation. Increased cyclic AMP or increased cyclic GMP increases the muscle relaxation. So the phosphodiesterase inhibitors increase the cyclic AMP level and help in relaxation of the muscles. I'm sorry. Yeah. So here you can see that The GQ coupled pathway receptors M3 bradykinin and H1 receptors on the endothelium. They stimulate the nitric oxide production. We stimulate the guanylate cyclase. Also, nitric oxide giving drugs, nitroprusside, hydralazine, nitroglycerin, nitroglyceride, all of them stimulate the guanylate cyclase activity. That will help convert the GDP into cyclic GMP. That will stimulate the protein kinase G, which is a phosphatase, and that inactivates the myosin light chain and helps in relaxation. Phosphodiesterase inhibitors like sildenafil, they inhibit the phosphodiesterase mediated conversion of cyclic GMP to GMP and help relaxation of the smooth muscles and thus help in erectile dysfunction. So over here, the calcium channel blockers of nifedipine, uh, they inhibit the calcium entry. Now, normally the calcium entry helps in calcium channel modeling system to stimulate the myosin light chain kinase. Also, the GQ coupled receptor, alpha M3 receptor on the smooth muscle help with this thing. If we give calcium channel blockers, so the contraction will not occur. Okay. So kind of a confusing graph. The Uworld point is that nitrates cause myosin light chain dephosphorylation. Kaplan point is that theophylline is adenosine receptor blocker by preventing the bronchostatic effect of the adenosine. Then another Uworld point is that increased level of cyclic GMP lead to decreased activity of myosin light chain kinase and myosin light chain dephosphorylation, resulting in the vascular smooth muscle relaxation. Another Uworld point is that cyclic AMP increases the conductance of the calcium channel in the sarcoplasmic reticulum, and as a result, more calcium can enter the cell and strengthen the force of contraction. Thus, the inhibition of phosphodiesterase isozyme 3 by melanin can increase the cardiac contractility. Now let's talk about calcium channel blockers. So the calcium channel blockers include amlodipine, clevidipine, nicardipine, nifedipine, nimodipine, dihydropyridines act on the vascular smooth muscles. Deltaism, verapamil, non-dihydropyridines act on the heart. Mechanism: they block the voltage-dependent L-type calcium channels of the cardiac smooth muscle, decrease the muscle contractility. Vascular smooth muscles amlodipine are nifedipine, deltaism, and verapamil. Heart, on the vascular smooth muscle, amlodipine and nifedipine have the most effect, then comes the deltaism and then the verapamil. On the heart, verapamil has most effect, deltaism is still in the middle, and amlodipine is equal to nifedipine has the least effect, right? So these are dihydropyridine calcium channel blockers, amlodipine and nifedipine, and verapamil and diltiazem are non-dihydropyridine calcium channel blockers. Do you remember that which of them are favorable in hypertrophic obstructive cardiomyopathy? These are verapamil and diltiazem, which are non-dihydropyridine calcium channel blockers. Okay, the clinical use: dihydropyridines except nimodipine are used for hypertension, angina, including the Prince metal and Raynaud phenomena. Nimodipine is specifically used for subarachnoid hemorrhage because it prevents the cerebral vasospasm. The cerebral vasospasm is one of the most commonly listed complication of the cerebral vasospasm or of the subarachnoid hemorrhage. Nicardipine, clevidipine, hypertensive urgency or emergency, and non-dihydropyridines hypertension, angina, and atrial fibrillation or flutter. Adverse effects include non-dihydropyridine are cardiac depressions, AV block, hyperprolactinemia, constipation, gingival hyperplasia, and dihydropyridines include peripheral edema, flushing, and dizziness. The effect of calcium channel blockers. The first one is dihydropyridines, amlodipine, felodipine, and nifedipine. Location of action is vascular smooth muscle. Physiological effects are peripheral vasodilation. The verapamil acts on the cardiac muscle, and the effect is reduced heart rate and myocardial contractility. Deltaism, vascular smooth muscle, and cardiac muscle combined effects. Then we have a Uworld point. The most frequent side effect of the verapamil is constipation, gingival hyperplasia, and heart block. Subarachnoid hemorrhage generates substances from blood clots that cause cerebral vasospasm, altered mental status, and focal neurological deficits in 7 to 10 days after subarachnoid hemorrhage. It is prevented by nimodipine. Nifedipine causes peripheral vasodilation, which may result in reflex tachycardia. Therefore, the antihypertensive drug is useful for the patients with bradycardia. Then comes the beta blockers, that is a bit lengthy. So we'll continue with the beta blockers in the next session. Until then, Allah Hafiz, Fi Aman Allah, and take care.